Afternoon, everybody. This is Dr. Jeff Gelblum coming to you live today, Thanksgiving Wednesday, where we are going to be discussing some very important information that really isn't even a week old. And that information relates to the new data regarding vaccination. As you are all aware, hopefully, there are now 3 vaccines that look like they are going to be FDA approved within the next several days, probably by, if not next week, the following week. And it's anticipated that distribution of these vaccines will occur probably sometime around the second week in December. So this is all very, very important for us who are living in the midst of the coronavirus pandemic. Here in the United States, we've got lots of folks watching today from overseas, so I welcome you. Bienvenue de mes amis français. But in the United States, we are really confronted with an enormous coronavirus pandemic. It is pandemic in that it's global, but truly in the United States, our levels are very, very high. We're experiencing about a 2% mortality rate. It's estimated right now that there may be between 300 to 350,000 deaths that are directly attributable to coronavirus as of November 25, 2020. And that is out of a probable overall exposure of 12 to 15 million people. So we are looking at an extraordinary epidemic, and as far as I'm concerned, the vaccination treatment cannot come soon enough. So purpose of today's discussion is really to decide who should get vaccinated. So let's take a look at the vaccination efficacy data, and let's take a look at the vaccine safety data. Because as a physician, we always have to say, well, what are the benefits and what are the risks of any treatment? So if you look at the 2 principal vaccines that were first defined and released, or I should say data came forward about 2 weeks ago. The first information came out with Pfizer, and the second information came out with Moderna. So those are the 2 vaccines that were the front runners. And let me explain very briefly about how those vaccines work. It's not like when you go to the pharmacy and get your flu shot. That's a killed virus. That's just giving you what is calculated to be this year's influenza attack. So you go, you get your flu shot, and that's how you're going to be protected against the flu, ostensibly for this year, because they've calculated, hopefully, that vaccine corresponds to this year's flu virus. But the Pfizer and the Moderna vaccines are entirely different. What those vaccines do is they inject you with messenger RNA. Remember, DNA is what defines your body cellular template. It's what makes you up as a human being. And then the RNA templates against the DNA, and it's the RNA that makes the proteins that create everything from hair or no hair, beard, nose, etc. So what happens with the Pfizer and the Moderna vaccines is they are injecting RNA into your body, and that RNA now goes into your cells, and those cells make the coronavirus spike proteins. In our previous Facebook Live episodes, we've talked about the different components of the coronavirus. It's a crown, that's what corona means, and out of the crown come little spikes. When you get an antibody test, for example, they're only looking at the crown, they're not looking at the spikes, and that's why the antibody tests for coronavirus, to see if you've had it, can be very much hit or miss, because those antibody tests are only geared to looking at the crown, or I should say the capsule of the virus, not actually looking at the spikes. But the vaccine development is geared exclusively to the spikes. So what happens with the Pfizer and the Moderna virus, these are brand new technologies, actually have never been used before in vaccine development. RNA is injected, messenger RNA is injected directly into your body via an intramuscular shot. And at that point, that RNA then gets into the cells, and the cells start to make these spike proteins that your immune system recognizes and says, holy smokes, this is something unusual and new. It's not part of me. I better make an antibody against it. I better start to drive an immune response against it. So that's the functional rationale behind the Pfizer and the Moderna viral anti-infectious studies, the vaccinations. And so far, that data really looks good. In fact, the Pfizer and the Moderna vaccine trials were started in springtime, and basically we've now got results. And that's an extraordinary thing. I mean, we're not even talking about 6 months after invention to pretty much result. And if you look at the number of people that have been vaccinated in the Pfizer and the Moderna trials, it's about 40,000 on the Pfizer side, 30,000 on the Moderna side. So you're looking at a group of 70,000 people total that have been vaccinated with this new type of messenger RNA technology. Those people received a shot. The shot contained messenger RNA. The messenger RNA goes into your cells. Your cells then manufacture spike protein, not virus, but just spike protein. And it's that spike protein that causes the immune system to cause an attack response. And once you have created that attack response and possess that attack response, then theoretically, if you are exposed to the real coronavirus, then you'll already have an immune system that's prepared to attack it with fresh memory and fresh response. So that is the rationale behind the Pfizer and the Moderna trials. And those trials appear to have good efficacy, meaning if we look at the patients or at the people who have received those vaccinations, those messenger RNA vaccinations, basically they look to be about 95% effective, meaning 95% of the time that vaccination should protect you from getting a severe, or actually I should say any coronavirus illness. Remember, the endpoint of the vaccination is twofold: to look at the antibodies that are developed in the bloodstream to protect against coronavirus, but also to look at disease. And it's been shown that vaccination with those messenger RNA viruses was 95% effective in protecting you from disease, and certainly did give you a robust antibody response, which means that's really, really good data. If we look at the early safety data with those two vaccines, again, they're very similar. You get the shot. There can be a little bit of redness, some headache, but this seems to be transient and certainly doesn't cause any acute illness. The major issue that we all have with this messenger RNA vaccination is that, yes, it's efficacious, meaning it works in a clinical trial. How that's going to translate into clinical effectiveness in a broad spectrum population is a different story entirely. And we really have to think about two words. Efficacious is what an FDA trial tells you how good the drug is working. Effectiveness is what happens in a large clinical cohort. So we've already established that millions of people have had coronavirus, and there are potentially millions more that could be infected. So the efficacy data is clearly great with the messenger RNA viruses, the Pfizer model and the Moderna model. The effects in the general population will probably be very, very robust. Luckily, the Pfizer cohort included a lot of age groups, a lot of different racial, ethnic groups. So there were African Americans, Hispanic Americans, Caucasian Americans. So very good broad spectrum trial looking at how different populations might respond differentially to the vaccination. So as far as I'm concerned, the efficacy data with both the Pfizer and the Moderna messenger RNA vaccine technology looks amazing. So that's that side of the story. But the flip side of the story is, what are the long-term side effects of messenger RNA vaccination? Because I told you this technology has never been used before. We don't know what the long-term side effects may be. The drug is a vaccine, or a vaccine is a drug. It's a substance that's being injected. It is messenger RNA. It takes hold of your cellular mechanism so that your cells make this spike protein. But what are the long-term side effects? Impossible to say. And it's impossible to say because the vaccines really have only been available in terms of technology or access for barely 6 months, and the clinical trials are still unfolding. Those patients are still being monitored, and I told you that the Pfizer and the Moderna vaccine models are looking at 70,000 people approximately. So 70,000 is a very good cohort, and that's a large population, great to assess efficacy, but is it good enough to assess long-term safety data? Well, it's probably good enough to assess short-term safety data. We know that patients who have received those vaccinations really are not developing any acute, life-threatening side effects that are of a very worrisome nature. But it's important to remember that long-term efficacy cannot be established on the data as it sits before us on November 25. So therefore, you have to scratch your head and say, okay, if I don't know much about the long-term data, but I do know that it's got short-term safety data and great efficacy data, then who would really be a good candidate for this vaccination process as it has now unfolded? As far as I'm concerned, our most vulnerable individuals are the elderly. We know that if you are over age 65, your likelihood of having severe side effects from a COVID attack are very, very large. I mentioned earlier today that the morbidity, or I should say the mortality, with coronavirus is about 2%. So 2% of the overall population will probably succumb to the virus, not survive. But that is a global number, and what it incorporates is extremely high mortality in very old folks and extremely low mortality in young folks. And all of us know people who have had coronavirus, and we all know children that have gotten it and have been entirely asymptomatic. We all know teenagers that tested positive and didn't have a sniffle or a cough. But on the other hand, we know people that have ended up in the ICU. And we do know older folks who have had significant problems with a COVID attack and have had significant illness. So therefore, we have to weigh efficacy, global population effectiveness, and then long-term side effects. So who should be the first rollout of this vaccination? Well, I want to tell you that the Moderna virus vaccination and the Pfizer vaccination, you're not going to see 100 million doses roll out from the get-go. Why? Because it's a very complex technology. What they're doing is they're taking messenger RNA, they're putting it in a nanoparticle type of delivery system. It's delivered at minus 94 degrees Fahrenheit on the Pfizer end and minus 4 degrees Fahrenheit on the Moderna end, which means it's not arriving in your average Whirlpool refrigerator. It's got to be kept under what we call extreme cold chain storage, and then it's going to be delivered to a facility that can possibly store it, and that's going to be a rather complex ordeal, because it's not, as I said, you're not just going to shove it in your sub-zero freezer and wait for somebody to come in and say, here you go, Dr. Gelblum, here's your shot. It's not going to happen like that. So there are going to be designated vaccination centers who will utilize the Pfizer and the Moderna products, but they're going to have these giant liquid nitrogen freezer systems that are capable of holding this for a significant period of time. Now, the good news is the Pfizer and the Moderna vaccines can stay under refrigeration for a few days, but from start to receipt by the vaccination facility, it's got to be kept under cold chain storage. So it's estimated probably that you're not going to be seeing more than several million doses roll out. So it's not like all of us are going to line up and say, okay, I'm ready for my vaccine. Where's the shot? It's not going to be available to us because there's just not going to be the quantity available. And also, we have to talk about the price. The price is probably going to be somewhere around $50 a shot for the Pfizer and the Moderna products. Remember, Moderna received federal funding, so there may be a significant price discount on the Moderna vaccination, but the Pfizer one didn't receive any federal funding, so they're probably within their rights to charge about $50. So assuming that we've got the $50 and we want to go over and get ourselves vaccinated, will we even be able to? And the answer is probably not, because there's just not going to be enough of this messenger RNA vaccine to allow us to have universal access. Again, that brings us back to the fundamental question: who should get it first? As far as I'm concerned, the people who should get it first are our most vulnerable citizens, meaning old folks. And we know that if you are 75 years of age and older, you should probably have the vaccine, because the risk of dying from coronavirus is far greater than in a younger person. And we also know, unfortunately, that if you're 75 years of age and older, long-term risks are not so important, because honestly, how many years do you have left? And I'm not being dismissive of old folks and longevity and, all of my patients who live up in the villages in Central Florida. But the point is, at age 75 and older, you are probably not to be too worrisome about long-term side effects from a new vaccine technology. So in that population, I think it's very reasonable to say, all folks over age 75, run right to Reed's. Reed's is a great pharmacy from my hometown in Baltimore, not in business anymore. They had the best crab soup you could ever imagine, but go right to Walgreens, go right to CVS, wherever it's available. Down here in Miami, designated centers look like it's going to be at Jackson Memorial Hospital. Up north of us in Fort Lauderdale, you'll probably have a vaccination center at Broward General Hospital or Hollywood Memorial. But the bottom line is, over age 75, go green light, do not stop, go get the vaccine, because A, we're not worried about significant long-term side effects in that population, because we know that the average longevity, at least at this time in the United States, for men is about age 78 to 80, and women a little bit higher, age 83. So if there are long-term side effects that are to be experienced, the older population is really not to be overly worried about that. So let's work our way down the age graph. So 75 and older, I think it's very reasonable to immediately sign up for that vaccine the moment you can get your hands on it at a designated vaccination center. You're probably not going to see it rolled out first at the pharmacy level, at CVS, at Walgreens, or at my favorite pharmacy in Baltimore, Reed's, which is no longer in existence. So let's talk about the next group, 75 to 65. Probably very reasonable. Not as strong of a green light as over age 75, which of course would include a lot of nursing home patients. But 75 to 65, I think also very reasonable. So what I think you need to understand is, right now in the United States, there are 30 million people over age 65. 30 million Americans are over age 65. You're probably not even going to see 30 million doses as this product is rolled out. And in fact, I anticipate that you're probably not going to see 30 million available doses sometime until well into the first of 2021. So as far as I'm concerned, the first people that need to get vaccinated are our most frail and susceptible to severe coronavirus injury. And that would be folks over age 75 and certainly folks 65 to 75. So that's 30 million people right there. And as far as I know, as far as the data that I've looked at, that's pretty much going to consume the bulk of the Pfizer and Moderna vaccines as they are gradually rolled out starting probably the middle of December. So I think our older folks are going to be the first ones that are going to be availed of the vaccine, and they should be availed because that's your most susceptible group. Now, you're hearing a lot about first responders, healthcare professionals, myself included. Well, this is what I think we always have to remember. If you are a young paramedic, is it worthwhile? Let's say you're a 30-year-old paramedic. Is it worthwhile for a 30-year-old paramedic, a 25-year-old nurse, a 28-year-old medical resident, a 40-year-old respiratory therapist, is it worthwhile for them to have a messenger RNA vaccine of brand new technology where we don't really have a lot of information about the long-term side effects? And to that answer, I'm going to say maybe not. And this is a little bit different than what you're hearing on the news media, and maybe even a little bit different than what Dr. Fauci is saying, because obviously it's very important that healthcare professionals, first responders, are protected. However, the question that I would ask any first responder who would walk into my office, or that I ask myself, is, all right, we don't really know about long-term side effects in a vaccine that's basically been invented just 6 months ago with a brand new novel technology. Is this something that you, John Smith, paramedic, age 40, would be interested in taking? And that's a real solid discussion. Just because one wears the doctor hat or the nurse's uniform or respiratory therapist or is a paramedic, we have to consider what their age group is and what their demographic is. And yes, they have higher risk of exposure because they're interacting with sick folks and a lot of COVID, but what's their likelihood of actually developing serious COVID-related illness? And what I would say to you is, if you're old, definite high likelihood of COVID-related serious morbidity. If you've got high blood pressure, yes. Diabetes, yes. Obesity, yes. Immunosuppression, yes, but I want to remind you, if you're immunosuppressed, who the heck knows if you're even going to make the antibody if you get the messenger RNA vaccine. So that's another question for another day that we can't even answer at this time. But I would always have to say, if you're a healthcare professional, first responder, and you're in your 40s, 30s, or 20s, I would really have to question the need for long-term exposure to a novel technology where we don't have that long-term safety data. But I also want to remind you that this may be an entirely moot point, because it's my belief that the first vaccine inventory that's going to come out, you're not going to have enough to do all the old folks and to do the first responders as well. So as I said, old folks run right to Reed's, get your vaccine. Younger folks, first responders, those folks who are not in that high risk morbidity age group or demographic, can probably afford to hold back a little. So that brings us up to the final vaccine where we've heard a lot of information about, and that's the Astrazeneca vaccine. So how does that differ from the Pfizer and the Moderna vaccine? Well, it's a completely different type of vaccine technology. What they do is they take a cold virus, the adenovirus, the old sneezy virus, and what they've done is they've altered that virus. They're injecting that virus into you, and that virus is now stimulating your body's ability to make antibodies against the spike protein. But that adenovirus technology, that's an old tried and true technology. A, it's not expensive. B, it's been around for years. C, it doesn't require ultra freezer refrigeration. And D, it's going to be cheap, much cheaper than the Pfizer and the Moderna viruses. So, and that's what I'm talking about with the British vaccine. That's the Astrazeneca virus. So this type of vaccination technology has been around for many years. We know about the long-term effects of it. Don't seem to be too bad. Yes, very rarely there can be an autoimmune response, but at least it's a known quantity, and we can say, okay, we've used this technology for decades. We know how it's going to work. It may not be absolutely as effective as the Pfizer and Moderna levels, which are 95% efficacious, but it seems like the AstraZeneca Oxford University product, that's one and the same, they seem to be at least 70% effective. And remember, the bar for vaccination is 50% efficacy. So as long as you're above 50%, the discussion as to, well, I want the 95% versus the 70% versus the 92%, it's a moot discussion as far as I'm concerned. So in summary, what we've got right now before us on November 24, weekend before Thanksgiving, are 3 vaccination products. Pfizer and Moderna, utilizing novel messenger RNA technology, injecting that messenger RNA technology into your body, assuring that your cells in the body will then make the little spike proteins that will then protect you from further coronavirus illness. And then we've got the Astrazeneca Oxford vaccination product, which is an altered cold virus, an altered adenovirus. So they're injecting a poor man's version of COVID into your body that just happens to stimulate spike protein formation. And that virus is probably a more reasonable, I'm not going to say better, but it may be more applicable in a broad spectrum population. Why? Because it's so much easier to manufacture, and it doesn't require all of the logistical constraints that are required with extreme cold chain transportation and maintenance, and it's going to be cheaper. So with that, we've covered a lot of information. If there's anything that you can take home from this message, it is, I think vaccination is imperative. When it first rolls out, the first people that should be vaccinated with a novel vaccine technology are the old folks, because in that setting, long-term side effects are not going to be part of a significant worrisome discussion. However, when we're talking about younger folks, people in their 20s, 30s, 40s, and otherwise healthy folks, where the epidemiologic risk of severe COVID-related death, disability, and disease is low, then it is probably, and I'm going to go on the mark saying here, it is probably better to hold off and wait to get a tried and true vaccination technology, because in this case, sometimes older may be better and more experienced may be better. But because of the urgency of the situation and because of the huge numbers that are spiking across our nation and elsewhere in the world, probably older folks should be first in line to get the messenger RNA vaccinations, because we know it's efficacious. And in terms of long-term side effects, we're not so worried. And we know that the early tolerability, the short-term tolerability, seems to be excellent. And I want to remind you that with these messenger RNA vaccines, you're going to need 2 shots. You get your initial priming shot, and then you have to get your second shot. So it's not just going to the facility one time. You have to go twice. And that's going to be the same thing, it looks like, with the AstraZeneca product. So it looks like there's going to have to be an initial dose and a priming dose, or I should say a priming dose, and then a treatment dose. And then who knows how long these antibodies are going to persist, and who knows how long the actual immune competence is going to persist. So we may be looking at annual revaccination. So with that, again, we have to put on our long-term concern hats, and we have to say, all right, new technology, I've got 30 more years to live. What happens if, something pops up after 10 or 15 years? We can't answer that question right now. So that's why sometimes I've been in practice for 20-some years, and I say sometimes the best medicine is old medicine, tried and true medicine. So from my perspective, me personally, I'm going to recommend the messenger RNA vaccines for my older folks, for middle-age and younger folks without significant health concerns. I'm going to say hold back. Let's see what the AstraZeneca viral data looks like. So far, the efficacy data looks good, and at least I know what I'm getting. So on that note, I'm going to wish you all a very happy Thanksgiving. I know we've got a lot of information to discuss over the Thanksgiving holiday. So if Uncle Zeke is at your table, take Uncle Zeke and get him the messenger RNA vaccine. But for those of us who are a little bit younger than Uncle Zeke, maybe we can afford to hold back. And I want to remind you, for the Thanksgiving holiday, don't pass the utensils around, serve it, and then that's it. And if people need to go back for seconds, you sit down, don't do any more serving, and say they don't need seconds because they're too fat anyway. So on that note, I'm going to wish you a very happy Thanksgiving. We've spent a lot of time today discussing these very important elements, and I may be coming back to you in the next few weeks saying, Moderna Pfizer data look great, so full steam ahead. Or I may come back and say, we've got some safety signals that need to be addressed. So this is the type of information that really requires your attention week in, week out, because it is constantly evolving science. So it gives us something to think about, and a heck of a lot better than discussing politics on Facebook. At least we're discussing science. So on that note, I wish you all a very happy holiday, and I look forward to taking any of your questions going forward. Please feel free to contact me on Facebook, or if necessary, email me at my office, jgelblum at fcneurology.net, like First Choice Neurology, jgelblum at fcneurology.net, and I'll be happy to get back to you as soon as I possibly can. Thank you again, and have a wonderful weekend. Bye-bye.